This is Catherine Poole, President and Founder of the Melanoma International Foundation. Please join us in welcoming Janet Abrams today. She is going to discuss pain management strategies. She is Professor of Medicine at Harvard and quite expert in this field. Welcome, Janet.
Thank you very much, Catherine. I'm very happy to be able to talk with your audience. I'm glad that they can use these slides as a reference from this webinar and also any archived editions. So let's get started. Next slide, please. There are a lot of ways to relieve your pain. Obviously, the best one is to eliminate the cause. So before you decide that, well, you just have to live with that pain, be sure that your physician doesn't have another way of eliminating the cause. Strange things like, I don't know, removing a clavicle if the pain is just there. Stranger things have been done. So just be sure there's no radiation therapy or surgery or any other specific treatment that might decrease the pain that you have from one of your lesions. This talk will focus on narcotic pain relievers and also drugs that help bone or nerve pain. I am not an expert in, but certainly there is excellent data for acupuncture, both for pain and for nausea and vomiting. There are also interventional techniques such as nerve blocks and also pumps that I'll discuss very briefly towards the end of the talk that are very helpful for very severe pain problems that just don't respond to any other treatments. Fewer than 5 out of 100 people actually will need those kinds of treatments. Physical and occupational therapy, heat, cold, and massage are effective for muscle types of pain, and utilizing counseling, meditation, and hypnosis are ways to get your head around the experience of pain. I'm happy to answer questions about those at the end, but I won't have time to go into those in detail in this hour. Next slide, please. You may be thinking that the usual treatment pattern is to wait until all the disease-oriented treatments for your melanoma are exhausted before your doctor focuses on symptom-oriented treatment. But this is the old way of looking at things. Next slide, please. Because there's no reason not to start symptom-oriented treatment at the same time as disease-oriented treatment. So from diagnosis on, whether you're in remission or relapse, or whether it's closer to the end of the course of your disease, symptom-oriented treatment focuses on maintaining the best possible quality of life for you. And symptom-oriented treatment is the expertise of palliative care doctors. So if you have the luxury of having a palliative care team at your site, it's very important that if you're suffering from pain, your palliative care team collaborates with your oncologist to get you the best possible treatment. Next slide, please. Now, as you know, your doctor is not a mind reader. By that I mean that I know that you're trying to be a good patient. I used to do oncology before I did palliative care, and the last thing you want to be is a complaining patient or the patient that always comes in with the problem. And you may not have as much time as you'd like during your visit with your doctor or your nurse practitioner to tell them about your pain. But they really have to know about your pain. And if they don't know about it, they really can't help you. So please be sure that you're offering them the fact that you're having the pain and that you really hope that they can help you with it or refer you to somebody who can help you with it. Next slide, please. There are a lot of factors that contribute to uncontrolled pain. The most common thing is that the pain medicine dose is too low. Some people resist taking more pain medicine because they think, oh, that must mean my cancer's worse. But that's not really true. A little bit of melanoma on the wrong place can make the pain a lot worse. So be sure that you take as much pain medicine as your doctor has allowed you to relieve the pain. Sometimes pain medicine is only taken intermittently, and then the pain returns. there are also psychological distress that can make your pain much worse. If you don't know what the pain is from, if you've just been told some bad news that the treatment isn't working, that really makes the pain hurt more. It's not in your head. It's all in your body, and your head is part of your body. And we'll talk about counseling and other sources of both counseling for psychological distress or spiritual concerns that you might need. You might wonder, how could a spiritual concern make my pain feel worse? Well, some people have actually wondered whether the pain they have is actually a punishment from God. It makes them feel that maybe they've done something that they really didn't understand that was wrong at the time, or they search for something that they did that was so wrong that God would punish them this way. And then sometimes they're separated from the source of their faith that could give them so much comfort. Sometimes the pain makes it so you can't even go to church or temple or pray 5 times a day as you want to. So there can be many spiritual concerns and lack of ability to do your spiritual practices that also make the pain just feel much, much worse. If any of these applies to you, please get the kind of counseling and treatment, or go to your spiritual advisor and see whether that could lessen your pain. Next slide, please. This is something that Cancer Care, that is a social work agency here in the United States, has articulated, and I want to be sure that you all hear this and know it and own it, because it's a Bill of Rights for people with cancer. I have the right to have my pain believed by health professionals, family, friends, and others around me. I have the right to have my pain controlled no matter what its cause or how severe it may be. Next slide. I have the right to be treated with respect at all times. When I need medication for pain, I should not be treated like a drug abuser. I have the right to have pain resulting from treatments and procedures prevented or at least minimized. Next slide. So how are we going to do that? Well, we can treat you while your cause is being determined. If you can't get the CAT scan because your arm hurts too much to put it up over your head, you need treatment for that pain before you get the MRI or the CAT scan. And you should know that cancer pain can be controlled even if the melanoma cannot be, and that most side effects caused by the pain-relieving medications can be prevented. But some people have what I describe on the next slide as unspoken concerns. And if you don't have these, your family might. Somebody in the family might wonder, or you might wonder, will I get addicted? What will people think of me? What will I do if the pain gets worse? Next slide. No, you will not get addicted. Addicts want to get out of their lives. You are using this pain to get back into your life. What will people think of me? They won't be able to tell any difference if you're on pain meds or not. And what will you do if the pain gets worse? You'll take more or a stronger medication. You can't use up your pain medication. It may have seemed like you could use it up if you had more pain, maybe because you had a recurrence before you knew about that. And it seemed like you had to take the pain medicine not just 2 times a day, but then 4 times a day, or then even 6 times a day, and the pain didn't get better. It wasn't because the pain medicine was used up. It was because there was a new problem that needed to be treated, or because you needed a stronger dose of that medication for the new pain. You can't use up your pain medicine. Take it to relieve your pain. Don't save it in case the pain gets worse. So what kind of pain medicine are we talking about here? Next slide, please. Well, pain is relieved by oral medicines or pain patches in over 90% of patients. That means 90 out of 100 patients will be able to have their pain satisfactorily relieved. I don't know that any of you listening here have only mild pain, but aspirin or nonsteroidals like ibuprofen or acetaminophen are helpful for that. They're all good for bony pain and tissue pain like muscle pain, and they can be added to the opioids in that moderate pain column. Could you go back to the previous slide? Thank you. codeine is not very often used for patients with melanoma. It's not strong enough, and it makes people nauseated, so I wouldn't focus on that. Hydrocodone is the medication that's in combinations like Lortab and Vicodin, and again, it's a fixed combination, so you can get toxic from the acetaminophen if you try to take too much of that. Usually what you'll need is some of the more severe pain medications, but oxycodone is one that also is combined with acetaminophen sometimes, and it's okay for moderate pain. But if it is combined with ibuprofen or aspirin or acetaminophen, you don't want to take more of those tablets because you can get toxic from the acetaminophen or the aspirin without even getting pain relief. Tramadol is an interesting medication that's good for the burning kind of pain you can get in your feet or your hands. It's a mild pain reliever. It's pretty good, but it's not good for the kind of severe pain that many of you may be experiencing. If you have severe pain, you need one of the opioids that's really very potent, like morphine or oxycodone, hydromorphone. A common name for that is Dilaudid. That's a brand name. Oxymorphone, I apologize for the typo, fentanyl, and methadone. Now, methadone you may have heard of is for drug addicts, for people who take it to not take drugs, but methadone is actually a wonderful pain reliever, and I will discuss that. I seem to have, if we can go to the next slide, please. So there are a lot of ways to get medications without needles. You can take the pain medicine by mouth, by a patch on the skin, which I'll describe. Buprenorphine and fentanyl come that way, and even as a suppository. Other ways are with needles, under the skin, into a vein, or actually we can give medications right on the spinal cord. If any of you have had children, the medication they put into the epidural was morphine, and it went right onto the spinal cord and was incredibly potent. And I'll discuss all of these ways. What if you're in a pain crisis? Let's go to the next slide and see what has to happen. What if opiate naive means that you've never taken a narcotic, an opioid? And all those drugs I mentioned, morphine, oxycodone, hydromorphone, fentanyl, methadone, those are all opioids. And the common word for those is narcotics. The way people treat a pain crisis depends on if you've been on opioids before or not. But let's say you've never been on opioids and you had really bad pain. The first thing we do is give you 2 to 5 milligrams of IV morphine or its equivalent. Some people get sick to their stomach from morphine, so we wouldn't give them morphine. We give them Dilaudid or fentanyl or something else. Now, the peak effect of an IV dose is around 5 or 10 minutes. So for the next bullet, we would reassess you 15 minutes after you got the medication. Next bullet. If your pain was unchanged, your doctor should double the dose. So if they gave you 2 milligrams, they give you 4 the next time. Again, we'd reassess you 15 minutes later. And if the pain is decreased, let's say it was a 10 and it went down to only an 8, then we repeat the same dose. Next one. And we would reassess you every 15 minutes, and we'd repeat until your pain had decreased to less than 50% of your original pain. So if your pain started at a 10, we would keep reassessing you until your pain got to a 3 or a 4. Now, this needs to be done in an emergency room or in a place in the hospital where somebody could monitor you very carefully. Let me show you an example of what might happen in an emergency room or a hospital room in the next slide. At 3 o'clock in the afternoon, your pain score was 10. So we gave you 2 milligrams. We reassessed you after you got it, and it turned out that you were still 10 out of 10. So at 3:30, we gave you double the dose. That was 4 milligrams. But you had bad pain. It was a nerve pain. And after we gave you more morphine and then we reassessed you, at 4 o'clock, your pain was still 10 out of 10. So this time, we gave you 8 milligrams. What this does is to build up a level of morphine in your blood to start to relieve your pain. By 4:30, we'd made some headway. Your pain was down to a 7, so we gave you the same dose again. And by 5 o'clock, you were doing much better. Your pain was only a 3. So at that point, we'd given you enough morphine that the level in your blood was relieving your pain. So you didn't need any more medication. We would reassess you every hour or so, and by 7 o'clock that evening, your pain was still a 3. So at that point, we'd add up everything we gave you and start you on a morphine drip so that we would maintain that pain relief. Some of you may have thought of a morphine drip as maybe something only you get at the end of life, but that's not true at all. It just means you're getting a continuous infusion of whatever opioid, Dilaudid, morphine, whatever it is, that you need to control your pain. Now, this is just an example to see, so you can see how fast your pain could be relieved. Let's say you did really well, and in a couple of days, you were still on, in the next slide, you were still on your 5.5 milligrams of morphine, and your pain was a 2 or a 3. Well, we'd have to figure out how to give you an oral medication. So we would multiply that 5.5 by 24 hours. That would mean 132 milligrams of IV morphine. But because when you take morphine, your liver metabolizes almost all of it. It metabolizes 2/3 of it. We have to give you 3 times as much oral to be the same as you had IV and give you the same pain relief. Now that looks like a whole lot of milligrams, I'm sure. But it translates into just 200 milligrams of sustained release morphine every 12 hours. That's why we gave you the IV, because it would have taken us a long time to get to that dose if we just did it orally, because you were in a pain crisis. We give you 10% of your total daily dose for your breakthrough pain, for pain that breaks through the continuous. And so your rescue dose is 40 milligrams. I'm happy to answer more questions about this later. But this is an example of how we would just very systematically go through, give you the pain meds you needed so that you were comfortable. So you go see your outpatient oncologist, and then later you tell them that your pain is, that's okay, the next slide please. You tell them your pain's well controlled, but your thinking is fuzzy. Next slide. So what should that oncologist do next? Should they lower the dose of the morphine? Well, wouldn't that make your pain come out of control? It would. So instead of that, they could add something that makes you think more clearly, like modafinil or methylphenidate. Both of those would make you think more clearly on the same dose of pain medicine, and you wouldn't lose anything. Now, some people find that their thinking is clearer on a different opioid, so your doctor might switch you from your morphine to oxycodone, sustained release, but in the United States, that's a very expensive drug because it's on patent. So how about fentanyl? Let's see about fentanyl. Next slide, I'm sorry. So how does a fentanyl patch work? Well, this is a picture of one. The little blue dots are the drug in a reservoir, and the black line is the sticky part that goes on your skin. As you see, the drug goes into a fat reservoir. It goes through the skin, it diffuses into a fat reservoir in your skin. And from there, it's picked up by the blood vessels and gives you pain relief. Now, what if you don't have enough fat? Then fentanyl is not a good drug for you. You have to have enough fat. If you could go back to the previous slide. You have to have enough fat to have a fat reservoir. It's also not good if you have a lot of tattoos, because the fentanyl won't go through. Or if you have a lot of fluid. Some people have a lot of fluid in their arms or their legs or their belly. If you have water, the fentanyl won't go through the water either. So fentanyl patch won't be a good idea for you. But for most people that have an adequate amount of fat, fentanyl is a very good drug, and it has to be put over the fat. So often it's put under the arm, sometimes in the place in the back where there's some fat. Next slide, please. Well, why not methadone? Methadone is actually a very good, if you could go back, methadone is a very good pain reliever. It's very good for nerve pain. So if you have a metastasis that involves your spinal cord, or one that involves the nerves in your neck, or the nerves that go down to your legs. Methadone works very well at very low doses, and it's very cheap. And your doctor may use methadone for you because it's very long-acting. You only have to take it a couple times a day, and it works very, very well. It does have some complications that we can talk about if you're interested in methadone, but the main one is it affects the cardiogram, so that your doctor will have to get a cardiogram, but in most patients that's not a problem. And it does take about 3 days to come up to its most active form. So by day 3 of taking methadone, that's the steady state of pain relief you're going to get. So we've talked about a lot of different ways to do it, so you should have it your way, as the next slide says. Because this is about you. Your pain relief is about what would work for you. So in pill form, if you need something immediate acting, like you're going to get on a radiation therapy table, you need it to work within 5 minutes, as though it were IV. You could do a fentanyl lozenge or a strip or a spray. That will work within 5 minutes, as fast as an IV. And it'll last about an hour, and then you get off the radiation therapy table, and you're done. There are short-acting tablets that act 3 to 4 hours, like oxycodone, morphine, hydromorphone. But then, remember, we said you need a long-acting pain reliever if you have pain that keeps recurring if you just take short-acting. So there are time-release pills of morphine, oxycodone, hydromorphone, oxymorphone. In the pill, it's either got little pillets, or it has a special formulation so that it releases drug over 8 to 12 hours. Or methadone is a long-acting medication. You could also take liquids in a spoon or a dropper. They have very concentrated forms of liquid. You can put a patch on the skin, fentanyl or buprenorphine, and it can be intravenous or infused under the skin very rarely. But whichever way works the best for you, if you're a person who's unable to take liquids, if you have a bowel obstruction, then you can have an intravenous or infused under your skin. But there's always a way to get you pain relief. Next slide, please. So to customize your regimen, you need to tell your doctor things like, is your pain constant? And by that I mean that even if you're taking pain medicines, does that pain medicine wear off and then your pain comes back? Because if it's always there, then you need a time-release pill or methadone or a skin patch, and you need an immediate or short-acting medication, because there's always that chance that the pain could increase between doses. Here in Boston, if you're bouncing through the streets in your car on the way to the appointment, that bone-jarring bounce could certainly make your pain get worse. But what if you're a person whose pain only comes and goes? Then you might only need an immediate or short-acting medication. And what if it's okay during the day, you can keep up with it during the day, but it interferes with sleep and you wake up with pain? Well, then maybe you want time release only at night, but during the day when you're awake and alert, you don't want as much pain medicine. You just take it intermittently. As you can see, there's a lot of ways to customize your regimen. Next slide, please. So why would your doctor maybe change your narcotic? Well, as I mentioned before, maybe you're too sleepy and you don't like the Ritalin, or you don't want to take another pill. If you have sleepiness that persists, they'll try another opioid. Or if you have nausea that persists. When you first start an opioid, you might feel a little nauseated, need to take some Compazine for a few days. But if after a week you still have nausea, they'll try a different opioid to see if you have less nausea. If you're confused, or if you just want to try something else, you don't like the patch, you want to try a pill, or if you're taking pills, but or for example, if you're on a patch, but you want to go on a cruise and you don't want that to be visible, they can switch over to time-release pills. Very flexible. Unfortunately, all narcotic pain relievers are equally constipating, so it doesn't have to switch from one to the other to have less constipation. Next slide. If you want to minimize the narcotics you take, you can add other pain-relieving drugs, which I'll mention in a moment, for bone pain or for nerve pain. You certainly can try acupuncture so long as your doctor approves. If your platelets are okay and your coagulation is okay, acupuncture can be wonderfully helpful. Massage, again, if your doctor approves. Some people like heat on their muscles. Other people have the skin is too hot, so they prefer cold. Meditation and hypnosis are ways to teach your mind to reframe the pain and to look at it differently. And so that can be a very effective way of helping it. And again, consider counseling, as we've decided. If you feel that there's anxiety, if there's spiritual concerns you have, the calmer you are in your mind and your heart, the less pain medicine you'll need to take. Next slide, please. So what if you have bones that ache or hurt when you move? Well, the oral medications you could take are acetaminophen or meds like ibuprofen or dexamethasone. All of those drugs actually improve the pain of when the pain comes from bones or comes from muscles that hurt when you move. Probably many of you have heard of bisphosphonates like Zometa or Rankle inhibitors. These are infusions of drugs that help bone pain. They stop the cells in the bone that are causing pain from being able to cause the pain. They don't treat the cancer. They just treat the cells that are responding to the cancer that's in your bone. And usually you get those infusions once a month in your doctor's office. Sometimes your doctor will recommend radiation to the bones or infusion of radioactive materials. But those are only done if you're not getting more chemotherapy or more targeted therapies, because the radioactive material can affect your bone marrow's ability to tolerate the other treatments. So you can ask your doctor about those kinds of treatments. Next slide. What if you have burning, shooting, or tingling pain? That means you have nerve pain. Your nerves have been irritated. So that can be because the cancer is invading the nerves or the treatment has irritated the nerves. Either way, or radiation has irritated the nerves. So dexamethasone, that's the drug you often take before your chemotherapy to help settle you down, also helps quiet nerves down. But so do other drugs that quiet nerves, anticonvulsants, which are normally quieting nerves so you don't have seizures, such as pregabalin or gabapentin. And then also tricyclic antidepressants, such as amitriptyline, they act differently on nerves, and they can be added to the pregabalin. They are sedating, so they're usually taken at night, the tricyclic antidepressants. If you have a place on your skin that's very sensitive, like after you had surgery and there's a scar, so that just the skin itself, when you touch it, is sensitive, you can use a skin patch that delivers a local anesthetic, like a lidoderm patch. And you can put as many as 3 of those on at any one time. Very rarely, as I said, if you have a problem in your spinal cord where the nerves are very much affected, or in the nerves that go out to your arm in that triangle kind of right above your clavicle. If you have shooting pains in your arms or terrible shooting pains down your legs or burning, medication can be delivered into the spinal fluid using the same kind of catheter that is used either as a portacath or just a regular catheter connected to a pump. The pump is put in under your skin. It's about the size of a portacath size, so maybe 2 or 3 centimeters. It's put under your skin, and it delivers either a narcotic or a local anesthetic or other medications right onto your spinal cord. Let me show you how that works. The next slide, please. So if you start out to the bottom right of the slide where it says noxious stimulus, that's what the pain is. It travels along nerves, transmission, into your spinal cord, which is the big circle with a kind of butterfly in the middle. It crosses to what's called the spinothalamic tract, goes up to the thalamus, and then to the cortex, where your brain perceives pain. That's how pain is perceived. And the brain tries to send down modulatory things to quiet things down right to your spinal cord. So how do some of these medications work? Next page. So the opioids work right at the spinal cord level. They're delivered in a catheter, and they drip down to where that big X is, and they block the ability of that nerve to fire. So if the nerve in your spinal cord doesn't fire, remember your spinal cord's that goes right down the middle of your back inside those bones that you can feel, and it's the nerve center, it's the telegraph wires that go to your brain. But if your brain doesn't get the message, you don't perceive pain. And that's how pain medicine delivered right onto the spinal cord, or an anesthetic delivered right onto the spinal cord, can prevent you from having pain. Now what about the side effects of the pain medications? Let's go to the next slide. The way I did this is as sort of a joke, which doesn't belong, and why. So if you're on pain medicines and you're constipated, one of these drugs is going to make things worse. Is it Metamucil? Is it Miralax, which is a polyethylene glycol laxative you can take? Is it Colace and Senna, which are medications that also help you have bowel movements? They're softeners and stimulants. Dulcolax is also a stimulant. Well, it turns out your old friend Metamucil doesn't work when you're on narcotics. It actually gives you more constipation. So if any of you are taking Metamucil to try to prevent constipation while you're on pain medications, please stop taking it, as Metamucil and pain medicines equal cement. So what can you use for your constipation? Next slide, please. You can use a stool softener like Colace, along with a stimulant. You'll almost always need a stimulant. Senna, 2 tabs twice a day is a starting dose, or bisacodyl, which is Dulcolax, 10 to 15 milligrams. There are things called osmotic agents, which means that they present the gut with so much stuff that water goes into the gut. And when water goes into your intestines, that helps you have a bowel movement. Now, lactulose is kind of a syrupy, sweet treatment that can cause gas if you're a lactose intolerant person. So don't take that if you're lactose intolerant. Milk of magnesia you all know about, and PEG is that polyethylene glycol. The Miralax is one example of it. It's granular. You mix it in whatever you like to drink. It has no taste at all, and it's a very gentle laxative. Go lightly is something that people use actually if they're going to have a colonoscopy, so that's much stronger, and I wouldn't recommend that unless your doctor prescribes that. Next slide, please. And finally, I wanted to just touch on that anxiety and depression make pain worse. So if you're feeling hopeless or worthless, if you're feeling guilty for the burden you're putting on your family, all of those things make your experience of your pain worse, make you suffer worse, make you have more distress. And all of these can be treated through counseling, through medications. Those are things to tell your doctor about or your NP about as well. Just like you shouldn't suffer from uncontrolled pain, you shouldn't suffer from uncontrolled anxiety or uncontrolled depression. Next slide. Because counseling and medications can provide the support you need. They can provide the knowledge you need about what's going on with your treatment and what you can really hope for and what the future looks like, and teach you some skills to manage your pain and your life more effectively. So we've come to the end of my part of the talk. Now it's up to you to ask me questions, and I'll do my very best to answer them for you.
Okay. Janet, I will be presenting to you the questions from our patients. This is Catherine Poole again, President and Founder of the Melanoma International Foundation. The first question I had for you is, are there differences in treatment for pain caused by surgery or radiation versus pain caused by the cancer itself?
So the pain caused by surgery, radiation, or the cancer itself, the treatment all depends on what's been injured. So if surgery has cut a nerve, then you need treatment for nerve pain. If the cancer invaded the nerve, you also need treatment for nerve pain. And same with the radiation. If that irritated a nerve, you need treatment for nerve pain. If the surgery caused muscle problems, you need treatment for that. So it's really more important what's been injured, because what's been injured is what's causing your brain to give you the report of pain. So all you really have to think about is what's hurting, not why it's hurting, not what caused it to hurt that way.
That makes sense. What do you think about the marijuana-based therapies? There was a study recently that found there was like a mist with cannabis that they worked with the opioids, and they were able to reduce the amount of the therapy by using this mist. Do you think these are good therapies? There's Marinol as well.
The mist is probably more effective because it's inhaled. Marinol and Nabilone are oral, and there's a very erratic oral absorption, so that if you really, the only way you know that you've absorbed enough is you feel kind of high and you get the munchies. It's true. That's why it works for nausea.
Right.
Now for pain, I would imagine that there's an anxiety treatment that goes along. There are receptors for cannabinoids, which is what marijuana is, in the brain. So there's something that we naturally make that our brain responds to that from. And I understand that there are early data that suggests that it works. Now, I don't know if it works directly through the pain perception or, as we've discussed, through decreasing anxiety. And whatever, however that works, it may help people if they have their anxiety decreased. What I don't know is if you get the other side effects, which is the feeling high and feeling kind of giddy, not thinking quite as well, and being a little unsteady on your feet. I don't know if you need all of those effects to get the pain-relieving effects. So I would counsel people to be careful about that.
Okay. So is that mist available? I just read a study about it.
I don't know that it's available commercially. But in different countries, different things are available. Like in the U.S., you can't use buprenorphine patches for pain control. You can only use them for addiction issues. So other countries might have something available that we don't have available. Or it might be available in a study form, but not yet commercially available.
Well, that sort of brings up the question about, what is available in, say, Europe that, is not available here. Are there differences in pain treatment in different countries?
Well, actually, the U.S., except for the buprenorphine, the U.S. is really almost the most generous and has the most options for pain relief. All the ones I mentioned are available in the U.S., except for the buprenorphine patches for pain relief. And I don't know if they will be used. In many countries, unfortunately, only morphine is available, and not even that. Germany has a lot of agents available. And in many places, fentanyl patches are available. But the U.S. really has the widest variety and actually has the highest opioid consumption in medical terms. For medical use.
It's actually a very old drug from what I've read about.
Yeah,
and it was developed very effective drug. And developed in Germany.
Yeah, Germany, but the German drug industry is terrific. And also Germany is much further ahead in the herbal supplements and natural pain relievers that I am not as familiar with. But Germany has a very large pharmacopoeia of naturally derived substances that they use.
Could you mention a few of those that you think that there's scientific value to? Some of the herbal.
It really does depend on how pure they are. I mean, the ginkgos can help you with alertness, for example. And ginseng can help with energy, but you have to be careful because it has platelet effects. So it's the kind of thing that if you have an herbal practitioner, I would suggest that you collaborate, your oncologist should collaborate with your herbal practitioner to be sure that the herbals that you're taking are not dangerous to you in terms of the chemotherapy drugs you're taking. But there's no reason they can't work together in selected cases.
Mm-hmm. Yeah, we usually actually suggest that to people, that if they're going outside traditional therapies, to be sure and tell their doctor what they're taking.
Studies have shown that a third to two-thirds of cancer patients go outside of traditional therapies because the untraditional or complementary, I like to call them, therapies offer so much in terms of mindfulness, as I said, the cognitive kinds of therapies, acupuncture, as well as just a holistic sense of who a person is. And unfortunately, sometimes we focus too much on the medical aspects and not the holistic sense of who a person is. So it's very common. But unfortunately, studies have also shown that people who do that are not telling their traditional medical practitioners as much about what they're doing, and I'm just worried it puts them in some danger.
Right. Exactly. I recall reading by Kubler-Ross that there was a cocktail that she found very effective that kept people alert.
That was called Bronson's cocktail. That's not particularly effective, actually. It was early on in England. Cicely Saunders, when she founded hospice, realized that her patients' pain was just recurring, and she saw no reason not to give the pain medicine on a regular basis for pain that was constant. Now, in the 1960s, this was revolutionary. Just 50 years ago, nobody was doing this. And they had a cocktail that involved some alcohol, some cocaine, and some heroin, actually. But heroin actually gets immediately metabolized to morphine. There is no advantage to heroin over morphine. By the time it gets to your brain, it's morphine. It's not heroin anymore. So that cocktail has not been proven, even by the British people, to be more effective than the agents by themselves. And it has side effects because when you put a whole bunch of things together, you get the unwanted effects of the ones you don't want. So here we would prescribe Ritalin, for example, along with an opioid to get the same effect. You don't need to have cocaine.
Right. Right. I know that that's a big complaint among patients is sleepiness and inability to stay aware or awake when they're on these other drugs.
Well, Ritalin has definitely been shown to be helpful, dextroamphetamine too. You'd have to titrate it. You start at maybe 2.5 milligrams at 8 and at noon, and then you increase it till you get an effect. And you may need to increase your dose as weeks go on. But it's very effective, and the short-acting works better than the long-acting, it seems, for this kind of, for alertness. But it works very well, and many people use it to be able to function at work or in their hobbies, or if they're performers, they use it before the performance. It's very effective.
Okay. I think a lot of patients, tend to not complain about this, to their doctors.
Yeah, they think that that's the price they have to pay. And I would say the theme of this talk is it's all about you. There's no price you have to pay. As I said, you're not a mind reader, and you have to tell your doctor. And they shouldn't lower the opioid dose. They should try something that actually will help you think better.
Right. And I always felt like people shouldn't be in pain. That there's got to be a solution.
There is.
To their pain.
There is. And now that the palliative care practitioners are so much more widespread, I would very much encourage all of the patients or their family members to ask for a referral to palliative care. And if the oncologist says, well, we're not ready to stop treatment, they can say, no, I don't want to stop treatment either. I just don't want to suffer so much.
Right.
There's a very good book called Handbook for Mortals. I don't know if you have that on your website. There's a second edition written by Joanne Lynn and Joan Harold. And it gives you answers to all these crazy things your doctor says to you. It's
Handbook for Mortals.
Mortals. It's a very empowering book for patients and families. And You just take it with you to the doctor's office and give them what for if they're not focusing on you and your comfort.
Well, I'm definitely going to get a copy of that.
I would recommend it.
Really,
second edition.
Yes, we very strongly believe that here at MIF.
Sure.
I talked to you briefly a little bit about an individual, and actually we have quite a few patients that do very strong therapies such as IL-2 and interferon and end up with some really debilitating long-term effects, and especially joint pain and shivers and so on, even long after they're off those therapies. So I wondered if you had any advice for them on how they might deal with that better.
If the joint, I don't know whether the joint pain will respond to non-steroidal or acetaminophen, and some people may need to take something like omeprazole, some kind of an acid inhibitor if they can to tolerate the ibuprofen. But ibuprofen often works better than the acetaminophen for joint pains and muscle aches. And then if you take a acid inhibitor, it can really make it much more tolerable for you to take the ibuprofen at the dose you need it, like at 400 milligrams or even 600 milligrams. The resetting of the hypothalamus that was described in terms of, I can imagine that the interleukins would do that. Certainly interleukin-1 is the thing that gives you a fever. So I'm sure interleukins do have when you give pure interleukin-1 to animals, that's what gives you the fever, the muscle aches, everything you get in the flu is exactly from that cytokine. So I'm not surprised that interleukin-2 might do something like that to the hypothalamus. And I know that we do give opioids for people who have shivers from amphotericin or for transfusions. I don't know. I asked my anesthesia pain colleagues, and I don't know data about this. I don't know whether a neurology consult would be helpful, because they might know more about people who've had strokes in the hypothalamus area, and so they might know more about how to treat someone who has an injury in that area. So I would certainly think about a neurology consult to see if they have some ideas about how to, especially a specialist who in hypothalamic type strokes or people who have injuries to that part of their brain. But I don't know of any data on what to do for that, and I wonder if the NIH has put out anything, since they're the one, Dr. Rosenberg is the one who gave so much of the IL-2. I wonder if, I don't know if Ann Berger is there, is the head of the Pain and Palliative Care Department at the NIH, Dr. Ann Berger, so you might check in with her. B-E-R, B as in boy, E-R-G-E-R. She has worked with Dr. Rosenberg for over 10 years now, I think. So she might have some ideas for you. I bet she's in those patients.
And it would be very similar to interferon, I'm sure, the same kind of.
Yeah, I'm sure it's the same kind of, Yeah. So interferon is often the flu-like symptom, and I don't know, again, if regular acetaminophen and ibuprofen might help with that.
Well, the patients I've talked to, they try everything, and
I bet
they get through. The first month is the high dose, and that's the really tough one for them. So how does one find a pain management specialist if they live, not near a university or what have you? I mean, how do you?
The first thing I do is go to the American Academy of Hospice and Palliative Medicine website. So it's the American Academy of Hospice and Palliative Medicine. They have information for patients on there. And I would certainly see whether they could find a palliative care specialist anywhere near them. If that doesn't work, I would call my hospice medical director, because everywhere has a hospice. Now, this isn't about end-of-life care. I'm not talking about end-of-life care, but hospice medical directors are specialists in treating pain and other symptoms, and they can do what's called a palliative care consult for people who are not on hospice. and they will have connections through the hospice, network. If they don't know what to do, they can collaborate with or contact someone in their hospice network who might know what to do. And I think that's a very underused resource.
Yeah.
We at the Academy of Hospice and Palliative Medicine have a certificate program that's going to be launched so that all the hospice medical directors will be able to take special training in palliative care because many of them are family practitioners or internists who are doing this because they care about the hospice program, but they didn't do a fellowship in palliative medicine. So we're launching a special training program for them so that they will be certified and they will have access to all that information. And as it is,
Wonderful.
just through the Academy, they can access all this information, all of our resources about pain management and other symptom management.
Wonderful. Yes, I think there's a strong feeling among patients and families that, the minute you say hospice, that means end of life. And in fact, it really means quality of life. I always refer to the people who work, in that field as angels because they really, really know how to make you comfortable, and it doesn't mean the end of life at all. So I think it's something people have to get over the word and look at palliative maybe instead as the word.
Yep.
Perhaps. So I really appreciate your time today. That's all of the questions we had, and I think you've really presented a wonderful program for people. And I want to remind folks that you have a book as well. You have a new one coming out. Can they have access to even it's a physician's guide, correct?
Yes, but it actually is good for patients and families too. I had to call it a physician's guide because I was told that that physicians wouldn't buy it if I called it anything else. But I know a number of people who are not doctors who've read it and who felt that they were very empowered by what was there. And the current edition is available on Amazon, and it goes through in much more detail all of the things we talked about today, as well as conversations, how to have right conversations with your doctor. It's just put from the point of view of a doctor reading it, but that doesn't mean that you wouldn't find it valuable.
Oh no, not our patients. They like me on top.
That's what I figured. So I think that it's targeted right for them. It sort of sounds like talking to me. My students tell me that when they read the book, it sounds like having a conversation with me, and that's exactly what I wanted. Maybe they can go online. I don't know if they can read a free chapter, I hope, or something online and see if they like the voice.
Right. So the new edition is what year then?
It won't be out till next year. I haven't finished it yet.
Oh, okay. All right.
But the second edition, the one that came out in 2005, is available. If there's nothing wrong with it, I'm just going to expand it in the third edition.
Right.
There's nothing incorrect, but I'm going to expand it a little bit in the third edition.
Wonderful. Well, it's a very valuable tool for sure, and an area that is forgotten, I think, much too often. And I really appreciate your time today.
Oh, it's my pleasure, and I hope it's enabled any of the listeners or any of your members to feel better. Then it's definitely worth my time.